Good morning, everyone who's here present and anyone online who is watching us. Hope you're having a nice day wherever you are. So I was just saying to somebody here, we put a picture of flowers up since we're heading into winter here, and it would be nice. So I'm John Messmer. I work at Penn State Hershey. I've been there a million years, not quite a million years, 29 years. So I do family medicine geriatrics. We're going to talk about a lot of stuff today. When I do these classes, everybody has a lot of questions, so I kind of thought, what do people typically want to know, and what's current, what's in the news, what's a good current health topic. So I just put a few things together. A little bit about vaccines. I get this every single day I practice, have to have a vaccine discussion with somebody about something. And the thing about vaccines is that a whole lot of the improvement in public health has come as a result of vaccines. And so I wanted to give a little history of vaccines. So I graduated from the College of Medicine in 1977, and we had this group here. This is what we got. And MMR was a relatively new, they had measles, mumps, rubella separately, but they were kind of combined. So kids came in, it was easy for me. How old are you? You get DPT, MMR, we'll see you. So I spent some time in the Navy, I came out, and by the time I got back to Palmyra in 1986, we had these. I had a misspelling, sorry. It's supposed to be a C there. So those were added to the regimen. Now, chickenpox, of course, is really common, and everybody thinks, oh, my parents had chickenpox parties. I want to get it over with, get my kid chickenpox. Unfortunately, the virus never leaves our body. Once you cure the chickenpox, you suppress the virus, and decades later, there's a possibility that your immune system will fail to suppress it, and it comes out as shingles, which is a very painful rash. So getting chickenpox isn't good. Now, we're giving chickenpox vaccine to a whole generation of kids, and we're hoping that we'll see less shingles later on. So meningitis, those are the ones that were added to the regimen. So wait a little while longer, and 1995, it became part of Penn State Health, and we got all these other vaccines. I mentioned we have Ebola and Mpox vaccines, but we don't see much of that here, fortunately. Strep pneumoniae, we call this the pneumonia vaccine. On the previous slide, that wasn't there, okay. We call this the pneumonia vaccine, but it's not so much for pneumonia. Strep pneumoniae is a version of strep. Strep pyogenes causes strep throat. Strep pneumoniae is a cousin. It is a very invasive organism, and it can kill you before you realize how sick you are. So we give that to folks as they get older because they're more likely to die the older you are. We do have a vaccine for herpes zoster, for shingles now, so all of us who had chickenpox as kids are at risk for shingles, and it's 2 shots to get you covered for that. We actually had an earlier shingles vaccine, which wasn't as effective as the one that's currently available. And then RSV, respiratory syncytial virus, is a relatively new one, and of course the COVID vaccine, which COVID is a virus that mutates like the flu virus, so we have to change it and update it. Fortunately, the original series still gives you pretty good protection. We're just trying to tweak it a little bit every time they update it. Respiratory syncytial virus has been around a long time. It can kill babies, and for a long time we gave, in the wintertime, we gave premature babies a shot of antibodies once a month to try to protect them. Now we have 2 versions of this. One version goes to pregnant women so that they will develop antibodies and pass them on to their child, and then the other one is for the rest of us. It came out with a recommendation for everyone over 60, then they said no, everybody over 65, and then they said no, we don't need to do it that much. Everybody over 75, but 50 to 75 if you have heart disease, lung disease, diabetes, that sort of thing. It doesn't hurt to get it. This vaccine, people get it and they say, did you give me a shot? It doesn't even hurt. So, and then there's a whole bunch of other things that fortunately we don't have to worry about much around here. But the point being is that now I have a chart, I have an app on my phone, depending on whether you've had one thing or another and what's due for it. I can't even do it from memory anymore. So it's very interesting. So what are you doing now? Well, you should have had all the childhood vaccines. If you are under 50 and you don't have any current problems like diabetes or lung disease, heart disease, you've got tetanus, diphtheria, and acellular pertussis. That's what Tdap means. The tetanus used to be separate. But diphtheria, we don't see it much in the country because everybody gets diphtheria. It used to be, it was tetanus, then it was tetanus and diphtheria. But pertussis, which is whooping cough, can be very prevalent. Adults can get whooping cough, but because our airways are larger, we don't make the whooping noise, but we call this the 90-day cough. Because if you get it, your airways are inflamed and you just cough and cough and cough. And it's not a nice cough, it's a bad cough. So we give that every 10 years and it reduces it. And the other thing is if you get Tdap and you're immune to pertussis, you're less likely to spread it to newborns. So if anybody has family members who are recently getting pregnant and going to be delivering, they may have come to you and said, you're an old person, you need to get a Tdap shot. So I get people, fortunately, I'm pretty good at keeping people up to date, and I have a lot of, no, you don't need it, you had it 2 years ago, that sort of thing. Human papillomavirus, I mentioned COVID and mentioned the flu. Human papillomavirus, I have question marks there because it all depends. We give human papillomavirus to children, both male and female. It helps to prevent them from getting the virus that can cause cervical cancer, and it can cause penile cancer, and throat cancer, and anal cancer, depending where the virus gets into the body. It's more effective if you get it in childhood, but it is actually approved for women up to age 45. Now, this is a sexually transmitted disease, and a lot of parents don't want to even talk about their kids ever having sex, ever. My daughter's not going to be sleeping around, so she doesn't need this. And so my response is, well, what about the guy she marries? Who's he been sleeping with? So, but everybody should get it. It drastically reduces the chance of getting, in fact, it practically prevents cervical cancer. So it's so effective that we've gone from doing pap smears every year for women of the appropriate age. So if you get a pap smear and get tested for the strains of human papillomavirus that cause cervical cancer and it's negative, you can get a pap every 5 years. That's how effective this is. So if you're 50 to 75, you should get the Zoster vaccine once. You keep your Tdap, your influenza, your COVID up. As you can see, age 65 is when we give people the Prevnar, which is the pneumococcal vaccine. Now there's also Pneumovax 23, so there's two different vaccines, and we used to give them both. Now, and then our CDC says, well, you know what, it doesn't make it any better to give both, just give the Prevnar. So there may be people, you among the audience may have had both, or you may have gone to your doctor and they say you had this one, that one. You only need the Prevnar 20, but if you get the Pneumovax 23, it's fine. I always say more vaccines are better than fewer vaccines. If you're over 75 now, as I said, RSV, but between 60 and 74 if you have other problems, and of course Tdap, influenza, COVID. And I love when my 90-year-old patients say, do we still need to get these shots? Yeah, because you're more likely to die now than you would have been when you were 60. Screening tests. So we have a lot. Here's another thing. We have the ability to screen for a lot of stuff. It used to be just paps and mammograms, but now we have the ability to check a lot of things. Colorectal cancer is increasing. I don't know why, but you're looking at it. So the first one now we're recommended age 45, or if there's a family history, sibling, parent, maybe aunt and uncle, if they have a history of colon cancer, we start you 10 years before the age that your family member was when they had their colon cancer diagnosed. So I have people in their 30s getting colonoscopy. If you've had multiple colonoscopies, or the fecal DNA blood, which is called Cologuard, that tests for abnormal DNA or blood in the stool. If that's negative, that's every 3 years. If you have a negative colonoscopy, it's every 10 years. And if you've had all the screenings and you get to age 75 and never had anything positive, you can stop at that point because you're much less likely to get colon cancer later. Not that it's wrong to do it after 75, but now if you've had polyps, if you've had the precancerous polyps, the adenomas, tubular adenomas, you keep screening until you've reached the point 10 years before you die. So if you're my patient and I say you can stop screening now, then you got 10 years. No, I'm kidding. It's really a hard thing. I have patients in their 90s who've had multiple adenomas, and the GI people send them to GI. You don't need to get screened, and so you're not getting screened because you have adenomas. It's hard to say because the risk of complications is higher when you get older. The risk of it, now it takes 10 years from the first time, approximately 10 years from the time the first cell transforms into a pre-malignant cell until it has the first actual cancer. So the thought is if you're 90, even if you're a great 90-year-old and you just had a colonoscopy and all the polyps are out, that it's going to take 10 years for you to get cancer, so why take the risk? And there's some argument to that, but so I always let people tell people what the thoughts are, and then we can go with Cologuard. That's always the other thing. Breast cancer. This is a lot of argument about when to start this, and it kind of depends on what your specialty is. But age 40 to 45 to 50, somewhere in that range, you should start getting them annually. There's one school of thought that says it should be every other year. So it really depends on the individual. Women with smaller, softer breasts without a lot of support tissue can probably get away with every 2 years, because the mammogram isn't perfect. Doesn't pick up everything. If you have very dense breasts, large breasts, you probably should get it every year. And sometimes you'll need to go something, instead of just a mammogram, you might get an MRI because it's more sensitive. So that's individual decision. Osteoporosis. So we've done such a good job with immunizations and screening tests and treatment of chronic disease, prevention of chronic disease, that everybody should live to be at least 65 or more. And if you're a female and you've been without estrogen for 20 years, you're at risk to get osteoporosis because estrogen keeps the calcium in the bones. So we start usually at 65. Thin women, frail women might get a little bit earlier. Some people start in the 50s. I have seen very few abnormal, probably no abnormal bone density tests for women in their 50s. But you can see, oh, you're a little bit low. We better make sure you get your calcium, do some weight-bearing exercise. So it's again, a lot of medical things is individual. And then repeating it, your bones don't change that quickly. If you could, we say every 2 years or so. If you start out with a reasonably good bone density at your first one, we might make it every 5 years or every 7 years or something like that. So a lot depends. Yes, sir.
Is there any way of reversing that?
Well, that's a good question. Yeah, if you have osteoporosis or you are at risk, if you have what we call osteopenia, which means low bone mass, there are various things we can do. First of all women should be taking 1,000 to 1,500 milligrams of calcium every day, either through dairy or through supplements. And then vitamin D is also part of that. There's vitamin D in almost every calcium tablet, but if there's any question as to whether you have adequate vitamin D, you can do a blood test and take supplements for that. That's the first thing. Weight-bearing exercises. Walking, jumping, running, dancing, weightlifting can help because the physical exertion on the bones or the muscles on the bone encourages the bones to get stronger. But if you do have significant osteoporosis or you're doing all that and you're still losing it, there are various medications that work to slow the loss of bone. So all our bones, all of us, are constantly remodeling. They're being broken down and built up, broken down and built up. Now, if you have hormones present, women before menopause and most all men, that buildup is sufficient to keep to meet the bone loss. Or if you do exercise and stuff, they'll build up. There are other medicines that encourage calcium to go into the bone. So instead of preventing loss, they work to put more calcium in. Which one you would use depends on your circumstances and so on. So yes, you can treat a lot of the osteoporosis. Unfortunately, a lot of people don't get bone density tests at the first time we realize they have a problem is they fall down and break something. You shouldn't break anything when you fall. You shouldn't fall, first of all. But if you do fall, you really shouldn't break anything unless it's, really you fell down the stairs maybe, but you fell off the first floor of a balcony or something. But so you really shouldn't break, right, Bill? You shouldn't really break any bones.
Correct.
Yeah. So
He's against bones.
So if you do break a bone, we look and say, is this a fragility fracture? Is this because your bones are not strong? And you could be on medicine for osteoporosis at a much younger age if you start out with pretty thin bones and you break something. So yes, you can treat it.
Thank you.
We screen everyone for diabetes who's overweight. The recommendation is everyone 35 to 70. I actually start treating or screening adolescents and young adults who are overweight, or if you have a family history of type 2 diabetes, you can do, screen at one time just to see. Most insurances will cover screening for almost anybody for almost any reason because diabetes is so prevalent. 60 to 70% of America is overweight or obese, and obesity is what causes type 2 diabetes. And a simple blood test. Cholesterol. So the official recommendation is to start screening at age 40 to 75 if you have one or more risk factors and 10-year cardiac risk of 10% or more. But we found out back in the Vietnam War that 18-year-olds start to get atherosclerosis. The autopsies on soldiers who were killed showed that they had the start of atherosclerosis. Atherosclerosis, hardening of the arteries, that is the thing that causes the clogging that can lead to heart attacks, strokes, and all the other things. And I have a different view of this. Cardiologists will say, for example, if you're 40, 35, 25, and your cholesterol is pretty high, there's a calculation you can do, which I'm going to show you in a minute, calculation where you can estimate the 10-year cardiac risk. So if you're 25, your 10-year cardiac risk is pretty low, but your cholesterol could be really high. Now if you wait 20 years, your cardiac risk is going to be pretty high. And my philosophy is, I don't worry about 10-year cardiac risk, I worry about a 50-year cardiovascular risk. And if your parents had heart attacks and strokes, and you're 25 and your cholesterol's high, I want you on a statin, even though it's not by the book, because the decision to go on a statin is based on the 10-year cardiac risk. But cholesterol affects the brain, the kidneys, the circulation in the legs, and I am absolutely convinced, and it's really hard to prove, that most of the dementia is due to atherosclerosis. There was a study done back in the 90s, the nuns study. There was an order of nuns that volunteered to have their brains autopsied, and they had a lot of information about them before they died. There were some of the nuns who had dementia, and they had changes in their brain consistent with Alzheimer's, and but they all had one thing or another, diabetes or high blood pressure or something. There was another group of nuns who seemed perfectly fine, not a problem mentally. They died. They had all the changes of Alzheimer's, but no atherosclerosis. We know that things that can reduce your risk of dementia include exercise, quitting smoking, controlling your blood pressure, controlling your diabetes, and lowering your cholesterol. Taking a statin drug reduces your risk of dementia. And the problem with proving this is you have to take some 20 or 30-year-old kids and follow them for 70 years. And the people who did the study would be dead at that point. So really hard to prove, but you can't convince me that it's not atherosclerosis. Now there are some genetic things, there's these ApoE4 alleles and things like that. That accounts for about 4% of Alzheimer's, the genetic things. Most of it is atherosclerosis. But that's not official. You can't get on the, promote something. You can't promote a statin and say it's going to keep you from getting dementia because there's a lot of other factors. If you just take a statin but you smoke and you're overweight and you don't do any exercise, you might still get dementia. You get it a little bit later than you would have otherwise. Hepatitis C, it's recommended that everyone, it was originally everyone who was a baby boomer should be tested for hepatitis C. The reason being that hepatitis C was not detectable. We couldn't find the virus. It was called non-A, non-B. We could check for type A, we could check for type B. If you had hepatitis and it wasn't A or B, it was non-A, non-B. We finally called it hepatitis C. And now we can test for the various strains of hepatitis C, and there's treatment. Once we were able to detect it and treat it, it became a recommendation that we screen for it, because in the 40s and the 50s and the 60s, the blood may have had hepatitis C, but it was not detectable. So if you were in the hospital and you got an accidental needle stick, or you had blood, or you had surgery, it's a possibility that you may have contracted hepatitis C, and it stays dormant for a long time and begins to damage the liver. And if you see the liver failing, one of the things could be hepatitis C. So if we can screen for it and you have it, we can treat you before you get any disease. So, but now the most recent recommendation is to check everybody. Everybody, check everybody. I tell people we should do it, and insurance covers it, so we do it. I haven't found much, but it's out there. Okay, so this cardiac risk thing. I've taken some scenarios and run them through the calculator. So this is a white male, 50, total cholesterol 150, HDL of 40. And this means, when you do the calculations, their bad cholesterol, their LDL isn't going to be that high, but the formula does not include putting LDL, just the total of the HDL. Normal blood pressure, not on blood pressure med, not diabetic, not a smoker. This 50-year-old man's 10-year cardiac risk is 2.6%. So, and I probably wouldn't put him on statin because he's got normal cholesterol. So let's take the same white male, 50, now his total cholesterol is 220 and his HDL is 35, and that's going to give him an LDL, bad cholesterol level, something 150, 160, which is high in my opinion. I truly believe that a normal LDL is less than 100. And the reason I believe that is, when I started medical school, we didn't know what normal cholesterol was, and they tested all of us. I have no heart disease in my family at all. And I was 50 pounds heavier than I am now, and I smoked a pack and a half of cigarettes a day, and I did not one lick of exercise, and my LDL was 85, and my HDL was 42. That's one, it's one case, but over the years, I've seen many, many people. I've done thousands of cholesterol screens on people, and if you have heart disease, we want your LDL to be below 70. In some cases, we want your LDL to be down below 50. So if that's good for them, why is it not good for everybody? Now, frankly, if you exercise and you don't smoke and you don't have diabetes and you don't have high blood pressure, but you have a slightly high cholesterol, your risk of these things isn't that great. But how long are you going to live, and are you going to get something, in your 80s or 90s? So I usually recommend dietary changes, things like that, and then maybe a low dose statin. And there are a lot of physicians who have normal cholesterol who are taking a statin just because it does more than lower the cholesterol. It actually makes the inner lining of your arteries healthier, so that it's less likely to have anything stick to it. And I have normal cholesterol, and I take a statin because I want dementia. Actually, there's dementia in my family, so I don't want to get it. I don't know if it'll help, but I exercise too, and I don't smoke anymore. So, anyway, so this person has normal blood pressure, no other problems. Now his risk is now 5%, but I would put him on a statin because he's 50, and if he lives 30 or 40 more years, he might start getting some, brain problems or other things. The problem is, if you treat 10,000 people like this, a lot of them aren't going to have problems, but some of them are. But you don't want to wait till they get the problems and say, okay, now you need to be on a statin. That's why. All right, so now we got an underweight male, still has a high cholesterol, smoker. Now, this is what smoking does. It doubles your risk, basically. They have 11% risk. Another white male, normal cholesterol, normal blood pressure, just smoking gives them about 6% risk. Smoking itself is a bad. So here's the guy with no smoking, and here's the guy who smokes. It's basically twice the risk. So we get the female, pretty normal stuff. Because females, the estrogen is protective. So this woman and he has twice the risk that she does just for the fact of being male. Testosterone is a terrible thing. Another white female, now she is a smoker, she goes from 1.1, so she triples her risk by smoking. And if you take hormones after menopause and you smoke, I didn't put that in there, but it's way higher, way higher. So this is a female, normal cholesterol, normal blood pressure. She's diabetic and a smoker. You can see now she's up to 6%. So you go from 1% to 3% to 6%. Diabetes and smoking is bad. When I have smokers who are diabetic, I said, "Do you like your legs?" And they said, "Yeah." And I said, "If you want to keep them, stop smoking." Because diabetic circulation problems are a big deal. I'm usually not that flippant in the office. So here's the woman with diabetes, smoker. What was different? 4120. Oh, so okay, diabetic smoker, 6%. Now she's got high cholesterol. She's high blood pressure, on meds, diabetic, smoker, 27.7, 28% risk. These diseases are bad. And on and on. So, and I took a male with everything, and he's got 50% chance of cardiovascular disease in 10 years. So, smoking, diabetes. Now, if you're diabetic and you're controlled, that's okay. Your risk goes down. If your cholesterol is low, if your blood pressure is controlled, that lowers your risk. But you should exercise. Everybody should exercise. It makes a big difference. We screen people with blood pressure, we screen people for diabetes, we screen people, I love this. One of the things we're supposed to do is screen people for diabetes, or excuse me, for obesity. You know, how do you screen for obesity? You look at them. Well, but technically, you weigh a person and measure their height, calculate their body mass index, which is not 100%, because if somebody's very muscular, their body mass index may be higher than, but you know, are you fat? You have fat rolls here, and you know, so that's how you screen for obesity. And kids, a lot of kids are obese. It's really a problem. We look for high cholesterol, high blood pressure, family history, a lot of stuff. An aortic aneurysm. So current recommendation, I don't think it's changed. Men who have smoked at least 30 cigarettes in their lifetime, when they get to age 65, we screen their main artery in their abdomen for an aneurysm, for a weakening. It's only smokers that this happens to. So you can be 65 and have a lot of other troubles, but if you aren't a smoker, you're not likely. Why men? Again, testosterone may be a poison, but it protects you against a lot of stuff. Women aren't likely to get an aneurysm until age 85. And the thinking was that if we screen a woman for an aneurysm, we're not going to see it at 65. We might see it at 85, but by that point, if she's been a smoker and has other problems, she's not going to be able to tolerate the procedure. The procedure used to be a big open procedure where they would cut the part of the aorta out and put Dacron graft in. That's a huge, big deal. We have much better treatments now. And so we may see that recommendation change. And then I mentioned about pap smears every 5 years. There's a screen for lung cancer. It's not a great screen, but if you have a 20 pack year history and you either currently smoke or you quit within 15 years, and you're between 50 and 80, you can get a low dose CT scan that'll look for abnormalities that might be cancer. Now, it's not great, but it's something. The problem with it is they'll see all sorts of little things. We call them incidental and sometimes you might end up with a biopsy that you didn't really need. But it's there if you want it. I don't push it a lot, but I tell people it is there. It's not covered by a lot of insurance, but it's around $150 to have it done. And if you have one, you'll get one every year because they'll keep following all those little things. Prostate cancer, I have OMG exclamation mark. So if you get a bunch of doctors in a room and ask them what they think about this, they're going to be fists flying. No, not really. The thing about prostate cancer is there's three basic, they grade it according to severity and so on and so forth. I look at it as there's low aggressiveness, medium aggressiveness, and high aggressiveness. Screening will pick up the low aggressive ones, and you can tell by doing a biopsy. And then if you have a low-grade prostate cancer, you're going to be screened, you might get more biopsies, and it's probably not going to kill you. And so getting a PSA is actually more dangerous. A PSA is a prostate-specific antigen blood test. Getting the PSA is actually more dangerous, but you don't know if you have a low-grade prostate cancer. If you have a high-grade prostate cancer, it's going to kill you. I don't care how early you get it, it's going to kill you. You can treat it to keep it under control, to slow its progression, but they're not going to cure it. Even if you catch it early, it's unlikely. The medium grade is the ones we want. So we look at family history. If your father had prostate cancer, your brother had prostate cancer, if you're black, higher risk for black people. And we call this an educated discussion with the patient. Here's the risks from the test. If you have a high grade, low grade, medium grade, your father had prostate cancer, your brother had prostate cancer, you're at risk, we should probably check you. There's no prostate cancer in your family. I haven't had a PSA done for like 20 years. There's no prostate cancer in my family. I'm not worried about it. Now I'm 73, so too old to be checked anymore. But anyway, this is a very difficult thing. There's no easy answer. It's really it depends on the individual's personal and family history. It is not recommended. Well, it used to be recommended. Don't screen. Okay, that used to be the recommendation. Don't screen anybody. Then urologists got together and showed a lot of data and said, well, maybe we can help some people. So now it's an educated discussion with the patient and screen if everybody agrees. And yet they still hold these annual prostate cancer screenings at the med center, and it drives me crazy because it's not for everybody. It's for some. And skin cancer, it's not recommended that we screen people for skin cancer, but it's recommended that you look at your skin. If you have a question, you go to your doctor. And everybody has skin. Dermatologists will do it because that's what they treat. That's their organ. So they're going to want to look at you. Ideally, you have a family physician who has some knowledge of what bad things look like and either takes care of them, him or herself, or then sends you to somebody. Not everything that changes is cancer. Don't get a sunburn, wear sunblock. Probably not screening, but if you have lots of moles, if you have lots of skin coloration variations, you probably should get a look by somebody who knows what they're doing. I do a lot of skin treatments and procedures. I feel quite confident to be able to screen people. I found all sorts of early melanoma. So if you have a family doctor who feels confident, that's good enough, and then they can say, okay, I don't like this, they can either take care of it or send you to dermatology. But people who have nice skin that doesn't have a whole lot of stuff on it probably don't need to be screened regularly. And you know, we often say when you come in, we listen to your heart and lungs, we're looking at where most of the cancers are going to be anyway. So that's one quick screen. But it's a little bit controversial. It really depends on your background, whether you've had sunburns and so on. Acupuncture. So, short story. I saw my wife has arthritis in the lower part of her neck, and I was not able to help her with her pain no matter what I did with traditional stuff. She saw an acupuncturist just by fortuitous. We were on a cruise and there was an acupuncturist. She was treated 3 times and the pain went away. And I said, I'm learning to do this. So I did. I took a course, it was about 10 months long, very intense, and now I'm doing it. It started a long time ago, in the pre-Han dynasty. It was, people, they kind of, you know, if you don't have the internet and you don't have TV and you don't have radio, you don't have anything else, what do? You look at the stars or you look at your body and you start to check finding things. So they worked out these ways. They found that they stuck needles in some places that things got better. The idea is this energy, which we call qi, is a vital substance that comes from your parents when you're born. It starts out as what's called jing, and that's transformed into all these other things. There are a whole bunch, at least 12 main meridians and a few other meridians where this energy circulates. It starts in one area, well, it doesn't start, it's everywhere, but it's constantly moving. And it can get disrupted. If you get sick, if you get injured, if you have anything done, if you strain something, you disrupt the flow of the qi. And acupuncture restores the flow of the qi and then makes the thing better. And that's the idea. So, you know, as a Western doctor practicing for decades, I said, okay, that's good. Let's go. You know, I'll learn it. But as I've done it, it's like, okay, it works. You know, it's how there's a lot of things we do. How antibiotics work? We know how they work, but because they can test them. And actually, acupuncture has been studied. Somebody asked me earlier, why doesn't insurance cover it if it works? And the difficulty is it's hard to study. The gold standard for scientific studies is called a double-blind study, where somebody gets treated either with placebo or the active treatment, and the person who's studying them doesn't know which it is, and the person who's getting it doesn't know which it is, and then you analyze whether they got better. But you're putting needles in somebody, so you're either putting the needle in or you're not putting the needle in, and it's hard to do a double-blind study. They work all sorts of ways to do it, where they have people put needles randomly that are not in the regular meridians versus people who get actual acupuncture, and there's not a statistically significant improvement. And then how do you measure pain? Because pain is subjective. So, and pain is the thing that's usually studied mostly. There are some good studies that show that were done, and they're small, but it looks like it works. There's also some radiologists who are acupuncturists who've studied functional MRI, where you can see what part of the brain is working. We know that you have a sensory area in the brain, and if you stick a needle here, it's going to light that up. But there are other areas that are lighting up when you treat an acupuncture point. So it does something other than just, you know, stimulate pain fibers. So lots of different points. I still use reference charts because I can't memorize them all yet, but I'm getting there. The more times I do it. A lot of those 361 points, but there's lots of the traditional Chinese medicine, which is what TCM means. Traditional Chinese medicine, there are a lot of other points, and there are, but I can do a lot with the basic 12 meridians. So that's what it does. It redirects, it increases, decreases chi. We use needles, but you can also use laser light can be used, heat can be used, and there's something called moxibustion, which is an herb, mugwort that's dried and rolled up, and by using heat in various areas, electrical stimulation, there's a lot of different ways, but you stimulate the points. The needles are traditional, and it works very well. People say, oh my God, I hate needles. These are 38 gauge, so if you're getting a shot, you're using a 21 gauge, 23 gauge, maybe 25 gauge. The thinnest needle that we use for shots, like local anesthesia, is 30 gauge. These are 38 gauge, so the higher the number, they're really skinny, really skinny. And you can barely tell that they're going in. There are some points on the fingertips and the tips of the toes, and that does hurt a little bit to get a needle there. So, but it's not bad. So these are the kind of things that work. So again, my wife gets horrible motion sickness. Horrible. She can't be a passenger in a car without being sedated. And when I learned this technique, I put one needle in a spot called pericardium 6, and she can drive anywhere as a passenger and not be bothered. So it's very cool. We don't diagnose in the Western sense. You come in and you say, I fell, I hurt my arm, they say I tore a tendon here, I have pain, they don't want to fix it. I don't care what caused it, because the pain is here, and I work on the meridians that deliver pain to that area. And so you can be recovering from a fracture, you can have a torn tendon, you can have a sprain, it's all the same. This is a little bit about the theory. So I'll do acupuncture for anybody, so not just my own patients or Penn State patients. If you think you might benefit from acupuncture or you're interested, and I'm not really advertising this, but if people want to know, you can call the office and say, I would like to get set up for acupuncture, and we'll just get all the information we need, and we can set you up. So, there, that's the potpourri. Any questions? Yes?
Your wife with her motion sickness, do you leave the needle in?
Good question. So you can. The needles are usually left in 5 to 10 minutes. Sometimes we'll use heat stimulation, depending on what we're treating, or electrical stimulation. But for motion sickness, we just put it in. And if a person has bad motion sickness or they get vertigo, when I take the needle out, I will put a spot in their ear. Interestingly, when I had these classes, they said everything in the body refers to the ears. There's a spot in the ears for everything. And I said, oh yeah, right. So, and then we started doing it, and I said, oh my God, I never realized that. So I'm going to send somebody out, and they'll have an ear needle. They're about anywhere from 2 to 6 millimeters long with a little adhesive. And I have one right here because I was having some problems with my fingers. So I would think of pericardium 6, and I would put something in their ear. Or I can even sometimes put one right back in that spot. And if they have really bad motion sickness, I'll send them out with a needle that'll last about 2 weeks. And the longer you treat, sometimes the better it is. So once that needle comes out, you may be free of the problem for a while afterwards. Tasha tells me also that when I treated her for motion sickness, that her nodes went away. I wasn't specifically treating that, so that was interesting. Yes, sir.
John, what little I know about this, my question is, I think in traditional Chinese theory of acupuncture, that you mentioned 361, I heard 365. So basically, to me it seemed like that was a cottage industry of explaining things, why 360, why one for every day of the year to explain all these meridians.
Yeah.
Now, what you're describing is more empiric. You stick a needle in, I stick a needle in my hand and my shoulder feels better, or vice versa. What's your thought on that?
Yeah, so in the history of acupuncture, I had a much longer lecture for our department. When acupuncture was the purview of shamans and whatnot in China, they also, traditional Chinese medicine includes herbs and things like that too. And these people were just itinerant travelers who went from village to village, and they would treat people. And at one point, around 1300 more or less, the emperor banned acupuncture as being not scientific. And, but it was still being practiced by people itinerant, go around and I'll cut your grass and treat your, treat your with acupuncture. But as it got further and further along, in fact, the emperor banned the teaching of and the practice of acupuncture. But as it got more and more people were doing it, they started to say, okay, we can do it, but you have to only be, it wasn't the Chinese physicians that did it, it was the acupuncturists. And then in 1975, when Nixon went to China, and there was a New York Times reporter who ended up having an appendectomy with acupuncture anesthesia, and now all of a sudden everybody's interested. Now, it turns out that up till about that point, almost all surgery was done with acupuncture anesthesia, which doesn't work. It's really not, it helps sometimes, but most of the time it doesn't work. It works better for post-operative pain than it does for anesthesia. And now anesthesia used to be risky. Anesthesia is not risky anymore. It's like, it almost doesn't matter. It's so safe. So we don't need to avoid traditional anesthesia, but it does work well for post-operative nausea, post-operative pain, and so on. And more people began to write treatises about it, analyze it, study it, and as more people saw that it worked, it became more accepted. So that's kind of where we got with this. It's not random. It really is, as I mentioned, when they do the studies where the people treat in something that's not in a meridian, some people get an improvement. It's probably placebo, because if you actually do something to somebody, you're more likely to get a response than if you just talk to them. So there is everything we do in medicine has a lot of placebo effect. If I give you blood pressure medicine and you think it's poison and I'm trying to kill you, you're probably not going to get better because you think that, But there are a lot of people who can get better just because I say, do this, it's going to make you better, and they believe me. So, but there is something to this. As I mentioned, there's several articles with functional MRI where treatments are done and you can see the changes that are taking place in the brain. Other parts of the brain other than the sensory motor strips. The limbic system is part of it, but other parts of it too. So there is something to it. It's just hard to say. I can't give you an antibiotic and I say it interferes with cell wall synthesis of the bacteria, and we know how it works, but we don't know exactly how acupuncture works.
Thank you.
Yes, sir.
Question, not on this, but what's your opinion about semaglutides? They seem to be coming on like crazy.
Yeah, Ozempic and Wegovy, so the question is, what's my opinion? Well, I think they're great, but like any medicine, they're great with a caveat. Yes, people get good results with that. Now, if you take it for weight loss, it can help with weight loss. And you can lose 15, 20% of your body weight, but you have to keep taking it unless you dramatically change your lifestyle. But not all overweight is lifestyle, it turns out. It's probably a lot of environment. Our food sources have changed so much over the last 50 years that a lot of it, in my opinion, is because of the food that we eat. In a lot of cases, it's not too much food. And the other thing is, if you've already gained a lot of weight, if you're 50 pounds overweight, 60 pounds overweight, people tell me I don't eat very much, and I say, yeah, I know you probably don't, because maintaining weight doesn't take many calories. Losing weight takes a dramatic reduction. So what Wegovy, what the semaglutide and similar ones do, they interfere with, they basically suppress appetite, they slow the gut down. They also affect the way insulin's released and so on. This is why people get their diabetes improved even before they start losing weight. So they are good. It's injectable. There could be some potential side effects long term. We're really looking at that right now. Not everybody can take them because they do give you a little nausea initially, and sometimes the nausea is really severe. So if someone has truly done everything, they're exercising, they're really cutting calories, and they can't lose weight, it's reasonable to get them going. And they might, we don't know, you might be able to get off of it at some point, but that still remains to be seen. It's still too young an issue. So it's a reasonable option. It doesn't make you get thin, it just makes you lose up to 15% of your body weight, and you probably will have to take it for a long time.
Thank you.
You already alluded to this a little bit earlier, this whole issue of how insurance controls screenings and so forth, but, you know, in some cases, they have these charts that if you don't smoke or don't smoke enough, you don't qualify for certain kinds of screenings, which seems unfair to the person who may have an issue but can't get it covered for screening.
Yeah. So that's like the CT scan for lung cancer. If you quit smoking more than 15 years ago, it won't get covered, because if you're going to get lung cancer, we know it by now. And that's why. And if you haven't smoked more than 30 cigarettes, so statistically, there's something about 30 cigarettes. I mean, whoever counted how many cigarettes? I smoked 1 pack and then quit. But if you were a smoker in the past, and it's been less than 15 years since you quit, or if you're still smoking, you're higher risk, so that's what we covered. You know, if when you're looking at what's the most cost-effective use of the money, you don't want to screen women for prostate cancer. You don't want to screen men for cervical cancer, right? So you don't want to screen young people for osteoporosis. They're not likely to have it. You don't want to screen young people for colon cancer. They're not likely to have that. You want to get the people when they're likely to have the problem. So this is why there are certain restrictions. I don't always agree with all the restrictions, but I can understand somehow where they can sort of make sense. One of the biggest things is trying to get an osteoporosis screen in a woman who's younger than the expected age, and you sometimes have to get a pre-approval. You say, well, here's why I think this person should have, and it's almost always approved. There are some good reasons and there are some terrible reasons why they won't do things. You know,
It's just part of the hurdles you have to deal with.
Yeah, you have to prove. I think of it as I have to prove my competence to the insurance companies. Why are you getting that? Well, I'll tell you what. The big problem for a long time, a lot of the drugs that are very effective for blood pressure and diabetes and so on were branded drugs, so they were more expensive and there were restrictions. There's a whole group of drugs called SGLT2 inhibitors that are now pretty much the standard of care for diabetics and people with high blood pressure to protect the kidneys. And there are some generic ones now, but they were it's hundreds of dollars a month. And I have a person who's on 4 other diabetic meds and I need to add this, and they would say, well, yeah, it's approved, it's going to cost them a couple $100 a month, and they can't afford it. And I'm thinking, you'd rather pay for the diabetic complications later on. And so, see, this is interesting. We say, well, you don't want to pay for this now, but you'll pay for the complication later. But see, the insurance company's view is they might be insured by somebody else when that happens.
Not my problem.
So, yes, sir.
Acupuncture and shingles?
Yeah, acupuncture can help with post-herpetic pain from shingles. It's just like any other pain. It often helps. Now, neuritis and neuropathy is not quite as effective, but it does help. And so it can reduce, if you have really severe post-operative pain, it can make it better. It might make it go away. And sometimes, and you might need treatment periodically because the nerve is inflamed and the acupuncture kind of redirects the way the energy flow is. And at some point it might start feeling worse again, so you'll do it again. Kind of like, you do physical therapy and then later on you stop doing the exercises and you gotta go back to do the exercises again. Yes, ma'am.
Back to the vaccines, how often do you need the RSV?
We think RSV, the requirement for RSV is probably going to be once, but it's still a relatively new vaccine, and what they do, they'll monitor the population for incidence of RSV after the vaccine, or and do antibody levels and so on. So it could be that you would need a booster. We don't know that yet.
Okay, it's not annual at this point.
As far as we know,
Yeah. Okay, thank you.
not annual yet, but might be.
Like-
So a lot of the annual vaccines are because the virus changes. The respiratory syncytial virus is relatively stable. Influenza virus, COVID virus, when a virus reproduces, it invades the cell, it releases its genetic material, and then uses the cell's mechanics to make more of the genetic material. But the problem with COVID and with flu, different strains come in, you might be infected by 2 different ones. So right now there's some avian flu going around the country, and avian flu normally doesn't infect humans because our respiratory tract doesn't have the right receptors for it, but if it mutates a little bit, So some animals, like pigs, can be infected with different types, avian and human. And if it has two different viruses and they're reproducing in the same cell, they say, hey, I like that, your genetic material, how about if I take a little of that? And they'll mix it all up, and then they come out, and it's a mutated strain, and now they may have, the avian flu may have picked up the ability to infect humans from the human strain that was in there, and that's what happened way back when we had that big epidemic of avian flu. It just mutated. So COVID does the same thing. Yes, sir.
I think my premise of my question is correct. I think I saw that acupuncture can help mental illness. And if that's the case, is mental illness, at least to some extent, is it a physical thing or not?
Everything's physical.
Okay.
Mental illness is physical also, but there are treatments for anxiety and depression. I haven't done a lot of that with folks yet. I would like to be able to avoid people getting on tranquilizers, because as they get older, it's more dangerous for them. So that remains to be seen from my personal experience, but there are treatments for depression and for anxiety. There's an anxiety point in the ear. There's another point that it's called Shenmen. It's the feel-good area, so it kind of makes you feel better even if nothing's wrong. I usually add Shenmen when I'm treating anything, because it couldn't hurt. It might help. But schizophrenia, addiction, there are treatments for addictions. There are, that's like any other addiction, it's very hard, and all by itself it's probably not going to do it. But there are treatments for detoxification, and there are treatments to help with addictions, smoking and everything, and they help somewhat. It's not magic, but it can help. So acupuncture is not the be-all and end-all for almost anything, but there are some things that can help.
Thank you.
Yes, sir.
My tendency is to associate acupuncture with pain relief. In the situation of arthritis, they will magically take x-rays and tell me how bad my arthritis is, which I think is BS, but there should be a measurable effect of acupuncture on the arthritis itself then, right?
It doesn't change the disease.
It doesn't change the disease.
It just changes the response to the disease. So a year and a half ago, I was out running, which I've been doing for 40, 50 years, something like that. And I just all of a sudden had the most horrible pain in my knee I ever had. And to make a long story short, turned out I tore one of my cartilages. I went the traditional route, went to orthopedics, went to physical therapy, did everything I was supposed to do. And I was walking, but it hurt. And so I went to acupuncturists, because I wasn't fully trained at that point, and they treated me. I had one session, half better, but the third session, the pain was gone. Now, it's still there. I can, go, oh yeah, I can tell it's there. But I can walk, and I can fast walk. I can't run. I tried that, but the pounding on that ruptured cartilage starts inflammation, and then I got to go through treatment again. But I'll get on a treadmill and I'll fast walk and get my heart rate up where it needs to be. But the damage is there. So if you have arthritis, it doesn't make the arthritis better. What it does is it changes the pain response, and you'll still have arthritis. So if you have knee arthritis, and we make the pain better, but you go out and you say, I'm going to go climb mountains and jump out of airplanes or do something, you're going to make it worse, because the problem is still there.
This could be a generational question or an opinion, but when we were kids, we used to go out and play and do stuff and have a lot of exercise. And I'm seeing young kids today are on computers, on their phones. They have less exercise. Do you see a difference with young kids not getting as much exercise as what, say, you and I did?
I worry about them, yeah. There was also less obesity back then, but it might have been partly the diet they were on too. I would like to see everybody's cell phones and laptops hooked up to a treadmill.
Power that
you don't
way.
get any power unless you're actually exercising. But there are still kids who will go out for sports, or will just play basketball with a bunch of friends or something like that, tennis, swim. I mean, there's a lot of kids who will still do exercise. And there were, I didn't exercise at all my entire life. I just didn't, until I got into medical school and I said, I should be exercising, you know? So you can get to be an adult and you've been a sedentary kid sitting in front of a screen your whole first 20 or 21 years, and then get religion and start exercising. But it really be good to get them to do it earlier, you know? There's always going to be a group, so I do worry about that. I worry about that. One of the things that we do with our well child visits is we talk, how much time do you spend in front of a screen? Now, in school, they're in front of a screen a lot, you know? And like my stepdaughter, she comes home and she's in front of the screen doing her lessons. And then she stops, she plays games for a little while, and then she goes to bed at 8:40 every single night. She's the most compulsive kid I've ever seen. But yeah, we worry about that. It's a worry. We're seeing more diabetes in younger children because they're getting heavier. And I do worry that a generation will grow up with a lot of degenerative diseases that they weren't exercising. But there's going to be people who like sports, and there are going to be people who want to exercise anyway. And a lot of patients of mine, you know, they get they exercise religion in their 30s and 40s, and they'll take something up. Racquetball, you know, racquetball is great because it gets people out there, it gets them moving.
Maybe that's why God invented pickleball.
Or pickleball, sorry, that's what I meant to say. I beg your pardon. Yeah, pickleball is so, you know, really when it's a lot of the older adults are doing it because they can't be playing basketball with 20-year-olds. So playing pickleball with your peers, it's good exercise. Now, riding an electric bike is not much exercise if you let the electricity do the work for you. But if you exercise with the bike and then you hit a high hill and you got the power assist there, that's okay, I guess. The trick with exercise is you got to get your heart rate up to the target rate. So the target rate is 220 minus your age. 70% of that number you should try to hit and sustain for 30 minutes 4 times a week. And that's what you need for cardiovascular fitness. So Charlie's doing math. It's about 105, Charlie. And that's not bad, you know. So, and you can go higher than that. So that's the other question I get is, well, if my target rate is 105, 110, but I get 130 when I'm exercising, is that okay? Yeah, it's okay. Unless you already have heart disease, and then there might be some limitations. But if you're doing it for fitness, it doesn't matter if you get above that. But you just don't get as good a cardiovascular fitness if you don't hit that goal. Any exercise is good. If you say, I don't want to get that much, but I'll go out and I'll take a brisk walk, fine. Any exercise is good. You get better results if you get up to the target. Any other burning issues?
Good.
So it is just about time to end. Thank you all for your interest, and you'll see me around periodically, so if you have other questions. So when you were talking to me,
Thank you.
Thank you.
Thank you.